ले लेना, इसका लेना, टॉर्च ले। हाँ टॉर्च। It's
Okay,
now.
doctor, we are live. We can go live.
Don't speak now, please. Hello. Hello. Can you hear me?
Yes.
Yeah. So I think I'll start now.
Okay.
Yes, doctor, you can go ahead.
A very good evening to all the MOS members and the ophthalmic fraternity who have joined tonight for this last league matches that we have, the Clash of the Titans. I wish all the participants best of luck. All the winners are going to participate in the annual MOS final quiz, where the prizes are much higher and bigger. So we have with us, we have Dr. Sachin, the quiz master, the first quiz master, and Dr. Rohit Bam. They are both the experts in quizzing. So I have to Dr. Sab.
Good evening, sir.
Hello.
Taswala, sir, to switch off your sharing screen.
Okay. Who is sharing this?
It's me, Dr. Sai.
So I think you'll have to put it off, na? It's fine. Hello.
Yeah. Good evening.
Are we live already?
Yeah, we are live. We are live.
Okay. Good evening, everybody. From behalf of MOS, thank you, Taswala, sir, and thank you, MOS, for this opportunity. Let us start the quiz with the first question. We're paying tribute to our teachers. The first question is, identify the legend in the photograph. Is a Padma Vibhushan. Options are option A, Dr. Pran Nagpal. Option B, Dr. S. Dr. G. Rao. And option D, Dr. G. Venkataswamy. Your time starts now. Okay, last 4 seconds remaining. Okay, time up. The answer is none other than my teacher and mentor of Shankarantalaya, Dr. S.S. Badrinath. Let's move on to next question. Question on anatomy. Which of the rectus muscle is inserted closest to the limbus? Closest to the limbus. The option is option A, lateral rectus, option B, medial rectus, option C, superior rectus, and option D, inferior rectus. Your time starts now. Which one of the following is closest to the limbus? Last 4 seconds remaining. Okay, the answer was very simple. The answer is medial rectus. Let's move on to the next one. Which of the following nerves does not enter orbit through superior orbital fissure? It does not enter. Option A, second cranial nerve, optic nerve. Option B, third cranial nerve. Option C, fourth cranial nerve. And option D, the sixth cranial nerve. Which of the following do not enter through superior orbital fissure? Your time starts now. Giving a clue, it enters through a canal, not through the fissure. Last 2 seconds. Well, the answer is obvious. The optic nerve which enters to the optic canal, rather exits to the optic canal. Next question. Superior transverse ligament is also known as Lockwood's ligament, Sommering's ligament, option C, the roof, or the D, Whitman's ligament. Your time starts now. This is a ligament which connects the aponeurosis of the levator pulporis superioris to the superior rectus and the orbital walls. Again, anatomy question, anatomy question. Last 1 second remaining. Okay, time up. Answer is Whitnall's ligament. Again, a question on biochemistry. I'm asking very basic questions. Daily requirement of vitamin A by an adult man is option A, 350 micrograms, option B, 100 micrograms, option C, 600 micrograms, option D, 2000 micrograms. Your time starts now. 350, 100, 600, or 2000. Daily requirements of vitamin A. Last 2 seconds remaining for us. Okay, the answer is C, 600 micrograms. From the science, the commonest organism, the host of endophthalmitis found is option A, Streptococcus, option B, Staphylococcus, option C, Pseudomonas, option D, fungus, Candida. Commonest organism in post-op endophthalmitis. Your time starts now. Is it bacteria? Is it gram-positive, gram-negative, or is it fungus? If gram-positive, is it Streptococcus or Staphylococcus? Commonest organism, especially in post-op endophthalmitis. Last 2 seconds are remaining for us. Time up. The answer is Staphylococcus. Moving on to the next, again a basic science. The image produced by indirect ophthalmoscopy. All of us are used to the indirect ophthalmoscopy, but a basic optics question, is it virtual and erect? Is it virtual and inverted? Is it real erect or real inverted? Well, obviously we all know it is inverted. Is it virtual or real is a question. I'm giving you a clue. Time starts now. Is it virtual inverted or real inverted? Okay, the real answer is real and inverted. This is the name of the chart. It's available in everybody's OPD. Answer are options A, Ishihara chart, option B, Logma chart, option C, Amsler grid chart, and option D, Snell's chart. Ishihara, Logma, Amsler, or Snell's. Your time starts now. The clue, this chart is used for predicting a macular function or macular distortion. Very simple question. Everybody knows this. As suppose okay, the time is up. The answer is Amsler grid chart. Ishihara we know is for color vision, Logma we know for the visual acuity, Snell also is for visual acuity. All of us in this photograph of the OCT in our OPD, the different layers of the retina which is depicted as the 10 layers of the retina. We have to identify the layer which is highlighted here, the second white layer from the bottom. Options are A, ganglion cell layer, second, the inner nuclear layer, C, the ellipsoid zone, and D, the internal limiting membrane. Your time starts now. The clue is that this zone, the finding of this zone has a significance on the visual acuity prediction. It has a prognostic value. Is it ganglion cell, is it inner nuclear, ellipsoid, or internal limiting membrane? Last 1 second for us. Time is up. Obviously, the answer is ellipsoid zone. All the other layers on the inner retina, this layer is on the outer retina. OCT angiography picture is shown here. What is false about OCT angiography, which is not correct? Option A, it is non-invasive. Option B, we can see a flow pattern. Option C, it can demonstrate active leakage. And option D, it picks up ischemic zones. Your time starts now. Everything is good about OCT angio except this one feature. The clue is that it cannot, it is a limitation of eye kind of OCT angio. Clue is that. The time is up. all of us know it is non-invasive. It is the flow pattern can be seen. It does pick up the ischemic zones, but one of the thing about OCT, it cannot pick up active leakage. So it has a limitation diagnosing picking a leakage in a CSR condition. So the option answer is it does not demonstrate active leakage. Okay, we are all of us in a post-traumatic hypemia OPD. The source of bleeding, I'm coming to a trauma case now. A source of bleeding in a case of hypemia due to blunt injury is option A, circulus iridis major. Option B, circulus iridis minor. Option C, short posterior ciliary vessels. And option D, iris vessels. Again, anatomic question. Source of bleeding in hypemia, from where it bleeds. Last 4 seconds remaining for us. Okay, the answer is circulus iridis major. It bleeds from there. Coming to the uveitis now. HLA-B27 anti-uveitis is not associated with. Option A, Behçet's disease. Option B, ankylosing spondylitis. Option C, psoriatic arthritis. And option D, Retter's syndrome. All of us know it is associated with ankylosing spondylitis, so that is not the obvious answer. So I'm removing one option for your comfort. The time starts now. Okay, the answer is Behçet's disease is HLA-B5, not B27. I'm showing a fundus photograph. You have to spot diagnose what is yellowish lesion on the inferior and temporal retina looks like. What are they? Option A is retinal vasculitis. Option B is snow banking seen in past meningitis. Option C, Dallen-Fuchs nodules seen in sympathetic ophthalmia on BKH. And option D, is it a patches of CME retinitis? Is a spot diagnosis. Your time starts now. Blue is the depigmented fundus in the background. Making it simple by giving clues, I guess. Okay, time is up. Answer is Dallen-Fuchs nodules. These nodules are seen in sympathetic ophthalmia as well as in BKH. Okay, the clue was a depigmented fundus in the background. Okay, this kind of retinal fold extending to the periphery is seen in which kind of parasitic infection? I'm giving this is not a history of prematurity of this patient. So this is not ROP sequelae. So this kind of picture is seen in which kind of parasitic infection? Toxoplasma, is a sequel of Toxocara. Can it be seen in TB or is herpes simplex virus? There is no history of prematurity, so ROP is ruled out. The time starts now. Giving you a clue, this parasite is seen in dogs. Toxoplasma, Toxocara, TB or HSV. The time is up. The answer is obviously I'm seeing a fundus photograph, very obvious picture. You can see the disc, you can see the blood vessels. There is a whitish patch in the infratemporal area, which is below the retina also. The diagnosis obvious is what? Is it a BRAO? There is a branch retinal artery occlusion. Is it BRVO? Branch retinal vein occlusion. Is it a retinitis? The media is clear. Or is it the subretinal abscess? Artery, vein, retinitis, or abscess? Your time starts now. The clue is the patch. Look at the disc, the clue is also there. White dot on the inferior part of the disc. Okay, the time is up. Answer branch retinal artery occlusion. You can see a clot there in the disc along with the artery occlusion. You can see a whitish patch, a sectoral patch. Again, diagnosis very, very simple, straightforward diagnosis. You can see the fundus, you can see the optic nerve. The blood vessel is fine. The upper blood vessel, there is a big sectoral patch of hemorrhage in the supratemporal area. obvious diagnosis is it a central retinal vein occlusion, CRVO? Is it a BRVO, branch retinal vein occlusion? Is it a CMV retinitis? Or is it a CNV which has bled? The obvious clue is there's a vein occlusion. So your time starts now. Very, very simple clinical pictures. Everybody seeing these patients head opens. Okay, the time is up. The answer is branch retinal vein occlusion. Central retinal vein occlusion will have all of the hemorrhages all over the fundus. These are sectoral hemorrhages with a heavy crossing blockage of the blood vein. So the answer is BRV, branch retinal vein occlusion. The next part diagnosis. We are seeing a fundus, we are seeing the optic nerve, we are seeing a macroaneurysms all over the place. And there is an NV on top which is bleeding. Very, very obvious diagnosis. The options are option A, is it a proliferative diabetic retinopathy? Option B, is it a non-proliferative diabetic retinopathy? Option C, is it a hypertensive retinopathy? Or option D, is it anemic retinopathy? Again, a very common diagnosis day-to-day in our operating. Macroaneurysms, ecardiocytes, succinate, NV bleeding. The time starts now. I'm showing a very simple cases in day-to-day practice for everybody to enjoy the quiz. Not very high-fi questions. Okay, the time is up. The obvious diagnosis is a PDR, a proliferative retinopathy. Because NV which is bleeding also it is definitely a proliferative condition. Moving on to the next question. Moving neuro-ophthalm now. Corneal syndrome is not associated with, it is not associated with option A, ptosis, option B, meiosis, option C, enophthalmos, or option D, exophthalmos. Time starts now. Ptosis, meiosis, enophthalmos, or exophthalmos. What is not associated with hormones? Okay, your time is up. The answer is very simple. Exophthalmos. All of the three associated with hormonal syndrome. Next question. Again, a simple anatomic question from the author. The parasympathetic fibers, which are destined for pupil, reside in what? They do reside in medulla. Option B. They do reside in medial portion of third canine nerve. They reside in pons, or obviously they are residing in optic nerve. The time starts now. Obviously, they cannot reside in optic nerve, this is sensory nerve. So there's a clue. They reside in medulla, pons, or third canine nerve. Very simple question. Obvious answer. They reside in the medial portion of third canine nerve. Last question from my side, a simple fundus photographer. What are you seeing here? Is it optic nerve head coloboma? Is it optic neuritis? Is it papilledema? Or is it a morning glory disc? A slightly odd question I'm putting just to have a scoring competition for the last question. The rest all were very easy. Your time starts now. Is it a coloboma in the disc, or is it this is in the coloboma? Who I'm giving you already. Okay, the time is up. See, there's no around the thing. The disc happens to be an excavation. The answer is simple. There's a morning glory disc around. Thank you so much. I'm stopping my screen sharing now and handing over to Dr. Rohit for further questions. Dr. Rohit, you can take over.
Yes, thank you. My screen sharing is not yet enabled, I guess.
Rohit,
Yes.
in case Sachin can share it from his end if it is the whole PPT with him.
Okay.
I started.
He start.
Rohit, visible now.
Okay, okay.
Okay. So MOS Quiz, I am really thankful to the MOS, Dr. Jignesh Taswala, our president, And going straight away to the quiz. There are 20 questions and followed by the answers. In an 11-year-old child with the complaints of redness and discharge.
Doctor, can you go to the presentation mode?
You can just see
Okay.
the slide.
Right?
Yeah, perfect.
Okay. So what is this condition? It is a pseudomembranous conjunctivitis. It is allergic conjunctivitis. It is a OCP or ocular cicatricial pemphigoid, or it is an OSSN, ocular squamous neoplasia, ocular surface squamous neoplasia. So 20 seconds for the answer. So it's a conjunctivitis, whether it's a pseudomembranous, allergic, or whether it is a OCP or OSSN. So coming to the answer, it is obviously pseudomembranous conjunctivitis, where the membrane can very easily be peeled off. Going to the second question. Now this is a question of a corneal dystrophy. I am showing you a straight line photo and I am also showing you a histopathology section. So whether it is a granular dystrophy, whether it is a macular dystrophy, whether it's a lattice corneal dystrophy, or whether it is Rees-Buckler's corneal dystrophy. Again, clue is that this dystrophy is not extending up to the limbus. So in a case of macular dystrophy, it extends from epithelium to endothelium and it extends from limbus to limbus. So obviously macular dystrophy has been ruled out of those three. Last 2 seconds, and the answer is granular dystrophy. Now, we all know this person. You need to identify the gentleman, whether it's Charles Kilman, whether it's Rajvardhan Azad, whether it's Dr. V.D. Wangikar sir, whether it's Dr. Rasik Bihari Vajpayee, or whether it's Dr. T.P. Lahane sir. The one who very often participates in all sorts of OPLs or ophthalmic premier leagues, and this is one of the photos with a cup that he was able to win in a OPL. So he looks to be Indian. So Charles Kilman, I think, is certainly out of question. Out of these four, Rajvardhan Azad, Dr. V.D. Wangikar, Dr. Rasik Bihari Vajpayee, or Dr. T.P. Lahane. So last 2 seconds, obviously it is Dr. T.P. Lahane sir. So the next question is, based on this topographic picture, what is your diagnosis in a patient who is 53 years old male? Whether it's TMD or Terrien's marginal degeneration, whether it's PMD or pellucid marginal degeneration, whether it's post-LASIK ectasia or it is post-hyperopic LASIK topographic picture. 53 years old male. Again, 53 years and male. These are two sort of a clues that you can guess. PMD is very common in females, although can also be seen in males. So the answer is TMD or Terrien's marginal degeneration. Now identify the condition. This is a slit lamp photo and you are to diagnose as a spot diagnosis, whether it's cornea verticillata, whether it's dendritic keratitis, whether it's a Stocker's line, or whether that is a Hudson-Starley's line. Again, the clue would be this is a sort of a condition which is associated with as a side effect of some of the drugs that had been given to the patients on a long run. So obviously the clue gives you that it is not dendritic keratitis. So whether it's cornea verticillata, whether it's Stocker's line, whether it's Hudson-Starley's line. So the answer is it's a cornea verticillata, or it's also called as vortex keratopathy, associated with drugs like amiodarone or chloroquine or chlorpromazine, indomethacin, or tamoxifen, which is used for CA breast. So the next question, little not so easy. Identify the type of aberration and its Zernike's representation. Now we all know it's not only about the Snellen chart and visual acuity, but we had been talking in terms of aberrations. So whether it's a coma, whether it's a trefoil, whether it's a spherical aberration, or whether it's a tetrafoil. Aberrometry that we measure on an aberrometer, very particularly in a case where we are planning a refractive surgery, or even in a cases where refractive surgery has been done and we are planning a cataract surgery, we need to keep a watch on aberrations. So the answer would be it's a spherical aberration represented as Z40, and minus 0.2 microns is the normal aberration or normal higher HOA, higher order aberrations that we see in a healthy individual. Now, comparatively simpler question, identify the procedure which has been done or which has been shown in the photo, whether it's a Boston's K-Pro or a Boston's keratoprosthesis, whether it's a Pin2G keratoprosthesis, it's a MOOKP, which is called as modified osteoodontokeratoprosthesis, or whether it's just a simple corneal autograft. 20 seconds for all of you. Obviously, you're seeing something different, so it's not a corneal autograft. So whether it's a Boston's K-Pro or a Pin2G or a MOKP or a corneal autograft, I guess is a ruled out. So last 5 seconds. So it's a simpler thing. It's a Boston's K-Pro. So Boston's K-Pro is again two type, type 1 and type 2. Type 1 is in a wet eyes, and this is the type 1 Boston's K-Pro. Type 2 is in dry eyes, where we actually bring out the keratoprosthesis to the leads. Now this is a slit lamp photograph, and what is the most likely diagnosis? Whether it's an ocular surface squamous neoplasia, whether it is an inflammation of a episcleral tissue that's called as episcleritis, whether it's a pingicula or whether it's a Dellen. 20 seconds. You can see a sentinel vessel, and in a second photograph, it is being shown with a rose Bengal staining. So that could be a clue for you to diagnose it correctly. So last 2 seconds, and the answer would be it's an OSSN, ocular surface squamous neoplasia. It's diagnosed by conjunctival impression cytology and treated with a surgical management, although interferon alpha 2B is also now being recommended in a not so invasive carcinomas. Now, a simpler question coming to a cataract. What is MICS? Whether it's a medial incision cataract surgery, multiple incision cataract surgery, whether it's a micro incisional cataract surgery, or it's a manual incision cataract surgery. 20 seconds for all of you. MICS, that is being called in a cases where we are doing advanced phaco. Last 5 seconds. So obviously it's MICS stands for micro incisional cataract surgery. Now coming to a refractive surgery, which of the following is a contraindication for us to perform a phakic IOL or a ICL? LASIK reject, anterior chamber depth or ACD more than 2.8 millimeter, anterior chamber angle narrow, and high myopia with low pachymetry. Which of them is a contraindication? Obviously, we all know phakic IOL is very well being practiced in a case of LASIK reject. So out of these three, which would be a sort of contraindication for a ICL or phakic IOL, the newer phakic IOLs from Appaswamy as well as Biotech? So the answer would be anterior chamber angle narrow. We won't be going ahead with a ICL because we need a deep anterior chamber. Now, very important thing, we all are cataract surgeons. Accuracy of IOL is contraindicated in which cases? Whether it's contraindicated in high myopes, post-LASIK for myopia, nuclear sclerosis with a pseudo exfoliation, or post-LASIK for hyperopia. So there is a post-LASIK for myopia and post-LASIK for hyperopia, or whether it's contraindicated in nuclear sclerosis with pseudo exfoliation or in a cases with a high myopes. Very commonly used lens or sort of a premium lens that we use, it's contraindicated in, your answer would be post-LASIK for hyperopia, because that would add to the aberration again. So again, in a patient, there's a slit lamp photograph. What is the diagnosis? In a patient who gives a history of LASIK, which has been done maybe like 1 year back, whether it's a diffuse lamellar keratitis or DLK, whether it's an interface epithelial ingrowth, whether it's an interface foreign body, or whether it's interface fungal infection or keratitis. Now, in a patient who has undergone a LASIK maybe around 1 month back, if you see a patient with irregular astigmatism, relatively quiet eye, although you are seeing some sort of a haziness or a whiteness in a interface, what you do diagnose? So last 5 questions, 5 seconds for all of you. After 1 year, you are not going to see DLK or diffuse lamellar keratitis. So the answer is interface epithelial ingrowth. Now identify the surgical procedure done. Whether it's a TPK, that is therapeutic penetrating keratoplasty, whether it's a MOOKP, that is modified osteodontokeratoprosthesis, whether it's a Boston's keratoprosthesis, or whether it's an endothelial keratoplasty. Now these are the two slit lamp photographs, pre-op and post-op. You are seeing a corneal abscess in a first photograph, and you are seeing a photograph with a relatively clear cornea and some sutures there. So whether it's a therapeutic penetrating keratoplasty or MOOKP, that is modified osteodontokeratoprosthesis, whether it's a Boston's keratoprosthesis, we had seen the picture of Boston's K-Pro in one of the questions previously, and whether it's an endothelial keratoplasty or in a form of DSEK or a DMAC. So the answer is certainly, I guess all of you rightly guessed it, it's a TPK, that is therapeutic penetrating keratoplasty. We had removed the abscess and put up a nice graft with a 16 sutures in place. So again, coming to infectious keratitis. Now this is a slit lamp photograph in a 45-year-old male who's immunocompromised with a subepithelial corneal infiltrates and papillary conjunctivitis. What is the diagnosis? Whether it's a microsporidial keratoconjunctivitis, whether it's a microsporidial stromal keratitis, whether it's a HZO, that is herpes zoster ophthalmicus, or whether it's a dendritic keratitis. In an immunocompromised means he might be a HIV positive patient, 45 years old, and you are looking at a subepithelial corneal infiltrates, and once you evert the leads, you are seeing a papillary conjunctivitis or papillary reaction. So obviously it's not a dendritic keratitis because the question itself says there is a subepithelial corneal infiltrate. So dendritic keratitis is ruled out. So the answer would be A, microsporidial keratoconjunctivitis. Now identify the question, coming back to something very simple. Whether this shows a arcus senilis, whether it shows a peripheral ulcerative keratitis or PUK, what we commonly know, whether it's a simple Descemet's detachment or whether it's the presence of a Dellen. In a 65-year-old male, asymptomatic patient, whether it's a arcus senilis, whether it's a PUK, whether it's a Descemet's detachment, or whether it's a presence of a Dellen. So last 2 seconds, very simple. The answer would be it's an quiet eye. So it's not a PUK. You are seeing a clear cornea in the center. So no Descemet's detachment. There is no Dellen or saucer shaped depression. So it's arcus senilis. Now coming to the cataract or phaco again. What is a NIT stands for in a Phaco-NIT? Whether it stands for A, no incision technique, B, needle incision with tip, whether it comes from like in the form of C, normal infusion technique, or it's called as a normal intraoperative tension. What does NIT stands for in a Phaco-NIT? This was the technique which was devised by Dr. Amar Agrawal, and lot of buzz around in the initial days or a few years back. So what does NIT stands for? The answer would be, last 2 seconds, it's B, needle incision with tip. Now again coming to the Phaco, what is co in co-MICS? What does co stands for in co-MICS? Whether it means customized, whether it means coaxial, whether it means co-lateral, or whether it means collamer. So simple question, MICS we had seen was micro-incisional cataract surgery. So the next question to that is, what is co in co-MICS? Last 5 seconds. A, customized, B, coaxial, C, collateral, D, collamer. So the answer is yes, you have guessed it right. It's B, coaxial. Now coming to something, again, identify the instrument, whether it's an RK marker, whether it's an IOL marker, whether it's a toric marker, or it's none of the above. RK marker means whether it's a radial keratotomy marker, whether it's an IOL marker, whether it's an toric marker, which we use in a toric IOLs, or it's none of the above, it is something else. So RK marker is used more commonly when we are doing a penetrating keratoplasty or keratoplasty for our accurate suture placement. So one I had ruled out, that is A is out of question. So whether it's a B IOL marker or C toric marker or D none of the above. So yes, the answer is right. It is a toric marker to mark the axis of toric lens that we are going to place it. Now coming to a imaging modality, identify the imaging modality which is being shown. This is the how the image looks like, and this is the machine. Whether it's a AS OCT or intersegment OCT, whether it's a pentacam, whether it's a lippy view, or whether it's an aberrometry that we had discussed in one of the previous questions. A AS OCT, B pentacam, C lippy view, or D aberrometry. It shows a nice corneal section. It shows the iris. It shows the angles also, as you can see in the another photo. So you need to identify what is this imaging modality that is being shown. So yes, it is a AS OCT. That is the intersegment OCT from Visante, particularly from Zeiss. So coming to the last question, spot diagnosis. Topographic image has been shown, and what does this topographic image mean? Whether it's a keratoglobus, it's a atypical keratoconus, whether it's a normal cornea, whether it's a cornea plana, or it's none of the above. Interpret the topographic image. Again, the clue would be the K1, K2, or what you are seeing is in the range of 35.11 at 27 degree and 34.86 at 117 degree. And the average K, what it shows is a 34.99 with a cylinder of only 0.25 diopters. So keratoglobus is ruled out because there's not much of the cylinder. It can be a typical keratoconus also. It can't be normal cornea because K1, K2 seems to be flatter side. Whether it's a cornea plana or it's none of the above, the answer would be it's none of the above. It is a post-LASIK central corneal flattening. So this is about the 20 questions. Thank you. Thank you, all of you.
Thanks a lot, Dr. Rohit and Dr. Sachin Kabra for conducting this quiz. Fantastic. I think from the simple questions to the difficult, all were covered. All subjects were also taken care of. We are awaiting results. I think the results are already out. Can the slide display the results and upgrade the winners?
Yeah, the results are declared, doctor. You can see it on your phone itself. You want me to read out?
Yeah, please read out because I'm on the thing. There's a lot of noise also outside.
Okay, top 4, right?
Yeah.
Yes.
You have put it on the WhatsApp?
I'll do that.
One sec. Can you share it on the quiz group? Hello. एक मिनट चालू है. Hello.
Sir, uploading, just wait for a second, I guess.
Yeah.
Hello.
Yes.
Doctor, it's on the group now, WhatsApp group now.
Yes.
Yeah.
Yes. Put them
I'll
on the
just
WhatsApp
read out
group.
one by one. Just give me a minute. Yeah, the 4 winners are the first one is Dr. Rishabh Desai, 1063. Then we have Anindita Desai, 1065. Jay Prasad Bhaskaran, 1067. And Aparna KS, 1066. Can you just upgrade them on Zoom? RT, congratulations.
Thank you, sir. Thank you so
Hi.
much.
Can you introduce yourself one by one as you are upgraded?
Sir, I'm Dr. Rishabh Desai, working as a pediatric fellow at Arvind Eye Hospital, Tirunelveli.
Fantastic. So Did you like it? Was it difficult or was it fine or it was very easy?
No, sir, it was really nice. Certain questions were really difficult, but I really
Okay.
enjoyed it. It was a very nice experience, sir.
Hello, nice to talk to you. Are you an MOS member?
No, sir, I'll become right now.
बन जाओ फिर अपने को MOSCON में जो winners है उसको we have got bigger prizes there, much bigger than what you'll expect. So I would we would be glad to have you as an MOS member. I'll send you the details. You share the number. Sai, we have the cell numbers of all the contestants, right?
Yeah, we have.
Yeah. So we'll be contacting you and the prizes will be delivered at your doorstep. Don't worry. Thank you very much. Can we have the second winner online?
The second winner refused to come online, doctor.
Okay. Anyway, we wish him the best of luck. What is his name? Who has refused to come up?
Dr. Anindita Desai.
Okay. Any two more?
Dr.
Yeah,
Jayam
good
Prasad
evening.
is already here, doctor.
Good evening,
Yeah,
sir.
very good evening. Yeah.
Yeah. I am from Trivandrum.
Yeah. Congratulations. for
Amardeep
winning.
Care, Trivandrum. Yeah, thank you so much.
Okay.
Yeah, I have won a couple of times before too.
Fine.
Yeah.
Fine. So once
Yeah.
again, a big congratulations.
Yeah, thank you
And
so
I
much.
hope you liked it.
Yeah. Maybe some of the questions were too simple.
Yeah.
But then for me at my age, probably this gives me an opportunity to go back and read and, learn basically. Learning
Fine.
happens. Thank you so much for this. Yeah.
Thanks for enjoying, and
Yeah.
I hope you are also an MOS member. If not, I would.
I
Like
am.
to
I am.
welcome
I
you.
am. I am.
So nice of you, sir.
Yeah.
Thank you very much
Okay.
for
Nice.
joining.
Yeah. Thank you so much.
And,
Yeah.
Yeah. You'll be
Yeah.
participating in the annual MOSCON also. Request those who are the winners in the league matches. We are
Okay.
giving them an open invite to be part of
Okay.
the
Thank you.
final MOS quiz, where the
Yeah.
prizes are much bigger. So
No.
thanks
Yeah.
a lot for
Price is
joining,
not
sir.
very relevant. Participation is the most important point.
Yeah,
Sir.
that is more important.
Yeah.
I'm
It's the
sure.
price or its cost or the value. It doesn't matter actually. This participation
nice,
is
so
really
nice.
good.
I
Thank you
hope-
so much for this opportunity. Thank you.
I hope everybody takes the view like you only. Can we have? Thanks a lot, sir.
Thank you, sir.
Yeah, we are. So I think we are the third one. Who's it?
Dr. Aparna.
Aparna is here. Dr. Aparna has joined already.
Yeah, Dr. Aparna. Warm
Good
welcome
Good
and
evening, all.
congratulations.
Thank you. I'm Dr. Aparna KS. I'm from Trivandrum, and currently I'm
Wow.
doing my Orbit and Oculoplasty Fellowship from Aravind Eye Hospital, Tirunelveli.
So nice. I hope you have enjoyed the quiz very nicely. And
Yes,
was
sir.
it difficult or easy?
Some questions were difficult and some were easy, sir. Mixed, actually.
Fine. Being in a subspecialty, I'm sure it's going to be a little difficult to answer the rest of the questions. But you joined, it was nice, and you won also. Hearty congratulations. So be a
Thank you.
MOS member in case you are not. We'll welcome you for the final quiz also. MOSCON will be sending special invites to the winners.
Okay, thank you, sir.
So thanks for joining, and big thank you to Dr. Sachin Kabra, Dr. Rohit Bang, and of course Sai for all your technical support. This is the final of the league matches. We'll definitely have a grand time in the MOSCON quiz, the final quiz, where the prizes are also very attractive. So thanks everybody for joining.
Thank
And
you,
good night.
Taswala sir. Thank you.
Yeah.
Thank you.
Thank
Nice
you, sir.
initiative.
Take care. Sachin
Bye-bye.
and Rohit. Bye. Take care.
Take care.
Sachin sir, bye-bye.
Bye, Rohit.
Thank you, Sai.
Thank you, Sai sir. Thank you so much.
Thank you, doctors.